The liver disorders may demonstrate either as acute or chronic, focal or diffuse, mild or severe, or reversible or irreversible. The parenchymal cell of the liver, the hepatocyte, is lying in a cage of supporting cell, reticuloendothelial cells, and forming hepatocytes plates. The plates are in close contact with sinusoids formed by endothelial cells. Other cells present into the liver are the Kupffer cells. They are specialized macrophages, also lipocytes. They are lying between hepatocytes and endothelial cells. The functional structure of the liver includes the lobule. The lobule, portal triads are present, and the lobule is zonated. There is a functional zonation of the lobules formed. This is shown here. From zone 1 to 3, the oxygen consumption is highest here in zone 1. It is related to oxidative energy metabolism, while it is relatively low in zone 3. This zone is related to glycolysis and to lipogenesis. This slide illustrates the structure of the hepatocytes. It is clearly shown how the canaliculi are formed by apposition of adjacent cells. Let me mention especially the capacity for regeneration. It is good. For example, complete recovery is observed even after massive hepatocellular death, for example, in fulminant failure, and hyperplasia is observed after surgical resection of a section of the liver. The hepatocytes exert multiple functions. The normal liver is strongly involved in the energy metabolism as shown on this illustration. For example, carbohydrate metabolism, both glucose production by gluconeogenesis and glycogenolysis and glucose consumptions by glycogen synthesis are presented in the liver. Also, protein metabolism. Liver is involved in oxidative deamination and transamination, and especially into the urea cycle, allowing nitrogen to be excreted in the form of urea, the urea cycle. Finally, these are here the main processes illustrated related to the protein metabolism. The liver is also important for the lipid metabolism. It manufactures about 80% of the cholesterol synthesized in our body. This pathway connects the metabolism of carbohydrates with that of lipids. Also, it is responsible for the synthesis, storage, and export of triglycerides. This is the site of keto acid production, and it assembles, secretes, and takes up various lipoprotein particles. So, for example, VLDL, these are the distributable lipids, LDL taking back to the liver, to LDL receptor, and also it produces HDL. It is secreted in order to scavenge excess cholesterol. This slide illustrates the link between the capturing of the free fatty acids and chylomicrons by the liver and the exportation of fats under the form of VLDL. If prevented the exportation, this is the only form able to be exported, excessive production and deposition of triglycerides will be present. This is the mechanism of the steatosis, as we will mention later. This slide illustrates the mechanism of disorder of the lipid metabolism into the liver. For example, by ethanol, the oxidation is disordered A toxic substance, carbon tetrachloride, may block the metabolism of cholesterol and the Golgi complex damage, responsible for the assembling of the VLDL. If damaged, the VLDL release will be compromised. Thus, accumulation of free fatty acids and conversion to triglycerides will be observed. Hepatosteatosis. The liver is also responsible for the synthesis and secretion of plasma proteins, such as albumin, clotting factors, and hormones or their precursors. It is also responsible for stabilizing, transport, and storage of different factors. Another important function, this is the protective and clearance function, detoxification of ammonia in the urea cycle, detoxification of drug by microsomal oxidizes phagocytic endocytic functions of Kupffer cells, the specialized microphiles. The synthesis of glutathione is also done into the liver. The glutathione is crucial for preventing oxidative damage to cellular proteins. There are two major types of liver dysfunction. The first one is related to the hepatocyte functions, as already mentioned, hepatocyte dysfunction. And the other type of liver dysfunction, this is the portal hypertension. It is caused by the fibrosis in the liver, so the blood backs up and finds alternative routes back to the systemic circulation. There is a bypass of the liver and less effective filtration. There is a loss of protective and clearance function with the risk of gastrointestinal hemorrhage, development of engorged blood vessels, esophageal varices and other varices in adjacent veins. And another complication, this is the encephalopathy. They will be mentioned in details later. Now, the liver dysfunction summary. Cholestasis, disorders into the bile metabolism. It may be caused by several factors. Let me now review the types of jaundices. The jaundice or the icterus, this is the name of the yellow discoloration of scleras and skin because of increased bilirubin concentration in the body fluids. Usually the jaundice is accompanied by itching, pruritus, because of deposition of bile salts in the skin and altered level of endogenous opioids. This slide illustrates the three types of jaundice. First, hemolytic jaundice. Unconjugated bilirubinemia is produced because of the destruction of erythrocytes. The hepatic capacity to take up and to conjugate bilirubin is exceeded. It is shown here. The hemoglobin, after the erythrocyte destruction, forms. This is bilirubin is a metabolite of the hemoglobin. It is released into the bloodstream under the form of unconjugated plasma bilirubin. It is later captured by the hepatocyte and converted to conjugated bilirubin into the cell. However, this capacity to take up and to conjugate bilirubin being limited, accumulation of unconjugated plasma bilirubin and jaundice will follow the hemolysis, hemolytic jaundice. This is a common finding in hemolytic anemias. The second jaundice type, this is the hepatocellular jaundice. It is due to dysfunction of the hepatocyte. And the third type, obstructive jaundice, obstruction of a bile duct, for example, by a stone in cholelithiasis. This slide illustrates the mechanisms of the hepatocellular jaundice. First, the Gilbert Syndrome, because of the defect in the uptake of the bilirubin and the capturing into the cell, there is a decrease of the internalization and the level of non-conjugated bilirubin in the blood, in the body fluids, is elevating. This is the Gilbert Syndrome, defective uptake into the hepatocyte. Normally, the bilirubin taken is subjected to the influence, to the effect of an enzyme, glucuronidase, conjugating it and producing conjugated bilirubin. Glucuronidase is operating into the hepatocyte. This process may be defective as observed in Crigler-Najjar syndrome. Decreased glucuronidase activity and decreased conjugation of the bilirubin. And the third hepatocellular form of jaundice, this is the Dubin-Johnson and one more, Rotor syndrome, different syndrome, affecting the transfer and the excretion of the glucuronized bilirubin. Thus, in all these conditions, the concentration of bilirubin, either indirect non-glucuronized or direct glucuronized into the body fluids, may be increased. Let me note especially a severe complication of the hemolytic jaundice in newborns, hemolytic anemia in newborn. The increased red cell lysis, this is due usually to an autoimmune disorder, autoimmune hemolytic anemia, causes the increase of the unconjugated bilirubin level into the body fluids. So, this unconjugated bilirubin should be captured linked to albumin for transport. However, especially in premature infants, the albumin synthesis is low, so the free unconjugated bilirubin level is too high. The complexes formed are not sufficient to transport, so it will be transferred through the blood-brain barrier into the brain. Let me note again that in newborns demonstrate a relative high permeability of their blood-brain barriers. The maturation occurs later, so under this condition, the unconjugated bilirubin will be deposited into the brain, especially into the basal ganglia. There, it will produce degeneration and necrosis secondary to the deposition. This is known as scared icterus, a severe complication of the hemolytic jaundice in newborns, especially in premature babies. As already mentioned, the obstruction of the bile ducts also will cause release of glucuronized direct bilirubin into the body fluids, thus to produce jaundice. However, there is a detail. Sometimes the obstruction may be produced by a process into the adjacent organ, the pancreas, for example, a tumor, adenocarcinoma. The adenocarcinoma in the head of the pancreas may cause compression and obstruction of the ductus choledochus and thus to produce bile stasis and mechanic jaundice. So, obstructive jaundice in this case should be taken into consideration as an indication for a putative carcinoma, adenocarcinoma of the head of the pancreas. Obstructive jaundice, because of the obstruction of the common bile duct, is observed in head carcinoma of the pancreas. This slide illustrates the yellow discoloration of skin and mucosa in jaundice. because of the high level of bilirubin into the body fluids. A yellow discoloration is present even into the liver tissue, especially in hepatocellular jaundice. This slide summarizes the mechanism of liver injury and the demonstration of liver dysfunction. The first includes membrane damage of the hepatocytes. The second one is related to the damage to the canaliculi, disruption of some transport mechanism, transport pumps. The third one is due to excessive level of some drugs, as well excessive increased concentration of every chemical substance detoxified normally into the liver, also activation of the apoptosis, especially due to excessive binding to the TNF receptor, to the FAS receptor, and with consequent activation of the caspases and cell death, and finally inhibition of the mitochondrial function, thus inhibition of beta oxidation into the hepatocytes. These are the main mechanisms of liver injury and dysfunction. As a consequence, alterations in energy metabolism may occur, for example, hyper or hypoglycemia, hyperlipidemia, diminished synthesis and secretion of plasma proteins, thus producing hypoalbuminemia or clotting disturbances, and also loss of some protective and clearance functions. All these dysfunctions may cause diseases. Let's now discuss the pathogenesis of the hepatitis. First, acute hepatitis. This is an inflammatory process causing liver cell necrosis. Here, this is the scheme illustrating the evolution of different types of hepatitis. It may demonstrate clinically as an acute hepatitis or subclinically to evolve silently to a chronic state and later to cirrhosis. Now, acute hepatitis may evolve to chronic hepatitis or to progress to a fulminant hepatitis with massive necrosis or with acute hepatitis with progressive continuing necrosis. The continuing necrosis will evolve further to a state of cirrhosis or, in some cases, to a hepatocellular carcinoma that may both the cirrhosis and the hepatocellular carcinoma produce finally the death of the patient. The acute hepatitis may be due to a viral infection with hepatitis viruses A, B, C, D, and E, or it may result from intoxication, toxic hepatitis, from drugs, toxins, poison, and especially from alcohol. The hepatitis A virus, this is a small RNA virus. It is exerting its effect through direct killing of hepatocytes and producing secondarily an autoimmune response. It penetrates into the organism through a fecal oral route. The second, the hepatitis B virus, this is an DNA virus. It penetrates into the organism through inoculation, through the blood, body fluids, eventually sexual contacts. The damage is again mediated through an immune process. The third virus, the hepatitis C virus, this is an RNA virus. It penetrates through inoculation and it is characterized by progression to a chronic hepatitis in up to 80–85% of the cases. The fourth virus, hepatitis D virus, it is known also as delta agent. This is a defective RNA virus it requires the helper function of the hepatitis B virus, co-infection or superinfection. The process caused is much more severe. It is usually a fulminant or progressing to a chronic hepatitis. And finally, the fifth virus, the hepatitis E virus, this is again an RNA virus, less common. It is inoculating the organism through a fecal oral route. However, it may be extremely severe in pregnancy. It may progress to a fulminant hepatitis. Let me know that some other viruses, less specific as compared with the hepatitis viruses, also may cause hepatitis. For example, the Epstein-Barr virus causing the infectious mononucleosis may produce as a complication hepatitis. Cytomegalovirus, the varicella virus, the measles virus, rubella virus, among others, also may cause hepatitis. The distribution of the hepatitis is strongly dependent on the level of the health care. As you can see here, the white areas indicate the countries with low hepatitis rate. These are the North America, United States and Canada, Western Europe, Japan and Australia and New Zealand, while the other regions in the world demonstrate a higher risk in blue and higher incidence, higher rate of hepatitis in blue. The acute hepatitis typically resolves in 3 to 6 months. A duration longer than 6 months is an indication for chronification of the hepatitis.